Hello and welcome to JOMA's Women's Health Committee webinar on infertility. My name is Eileen Eliassi and I'm a second-year medical student at Renaissance School of Medicine at Stony Brook University. The Jewish Orthodox Women's Medical Association, also known as JOMA, is a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our department, the Women's Health Committee, was created with the goal of increasing access to women's health education to the Orthodox community, thereby empowering women to be better equipped as self-advocates. We believe it's important to know about our bodies, know what to expect when women see their doctors, and know which questions to ask. If you haven't done so already, please take a minute or two to fill out the pre-webinar survey. You will find a link to the survey in the chat. There will also be a post-webinar survey, which you will receive after the webinar. Please try to fill both surveys out, as this will help us conduct research on this education. Tonight, we will be covering infertility. We will be addressing the following topics: infertility in general, including costs, secondary infertility, fertility preservation, age-related infertility, male infertility, and menstrual abnormalities. We'd like to remind you that this forum is not a substitute for getting individualized medical advice from your doctor. There will be a Q&A at the end of the event. Please keep the questions broad. All questions should be posted in the question box. If you would like your question to remain anonymous, please hit the Remain Anonymous button. Your presence on this webinar is completely anonymous. Your video and voice are not enabled and attendees will not be viewed. Your presence here is completely anonymous. I will now introduce our first panelist. Dr. Valerie Libby, MD, MPH, earned her medical degree from the University of Texas Health Science Center at San Antonio. She graduated from the University of Texas at Austin honors program studying psychology and Spanish. She then earned a master's in global public health from George Washington University, where she served as a fellow in Kenya for the Global Health Service. After finishing her residency in obstetrics and gynecology at Parkland Hospital, University of Texas, at Southwestern Medical Center, she completed a 3-year fellowship in reproductive endocrinology and infertility at University Hospitals Cleveland Medical Center, Case Western Reserve University. Dr. Libby is board certified in obstetrics and gynecology and board eligible in reproductive endocrinology and infertility. She has expertise in the diagnosis and treatment of infertility, including polycystic ovary syndrome, male factor infertility, and ovarian aging. She is also accomplished in the areas of infertility, areas of fertility preservation and elective egg freezing. Dr. Libby joined Shady Grove Fertility in September 2020 and is seeing patients at SGF's Atlanta Northside location.
Hello, thank you so much for that introduction, and thank you all for being here tonight. And thank you, Joma, for inviting me to speak. I'm so happy to be here and honored, and can't wait to teach you guys everything that I think you might be interested in learning about fertility. So I will share my screen. Let's see. All right. So hopefully you all can see the screen. Okay. All right. So can someone just confirm that they can see my PowerPoint? Okay. All right. Thank you. Okay. So again, I am a physician for Shady Grove Fertility in Atlanta, Georgia. We have offices all over the country. We're the largest fertility clinic in the country. And I'm in the Atlanta office. We also have one in New York and in New York City, and then lots of other places. So I'm honored to be here today to talk to you guys all about infertility, the basics of infertility, and then we'll go into egg freezing. So again, I'm going to talk about fertility 101, what the egg freezing process is, success rates, what the financial options are for both egg freezing and infertility treatment. And we'll finish, at the end of both myself and Dr. Peiser's presentations, we'll try to get to any of your questions. Again, please submit it to the chat box, but make sure you remain anonymous or else we won't be presenting those questions. And let's see if you, so I know that Dr. Peiser is going to be talking a lot about the basics of fertility as well. So I'm going to go pretty quickly through that. And then she's going to, repeat a lot of things and go into more detail as well. Because my focus is going to, be more, I think, on the egg freezing and what that entails. So just in general, obviously what you need to make a baby, you need ovaries with good quantity and quality of eggs. You need sperm, and you need your fallopian tubes and your uterus to be able to be working properly so that you can, create the baby and that it implants into the uterus. And we'll go into that in a second. But just so you all know, the natural chance of getting pregnant every month is for a woman in their 20s is only 15 to 20%. So it does take time to get pregnant, even if you're young. And as we get older, pregnancy rates do decline with age, obviously. On any given month, a woman's body will recruit multiple eggs, only of which a few will mature. Well, one typically. So when an egg and sperm meet, fertilization will occur in the fallopian tube. And that means that the egg and sperm together become an embryo. So infertility is the inability to conceive a child after 1 year of unprotected intercourse. If you are equal to or over, if you're between 35 and 40, we define infertility if you've been trying for 6 months. If you're older than 40, then it's between 40 and 43, it's 3 months. And if you're older than 43, you should see a fertility doctor if you want to get pregnant, period, immediately. Also if you have irregular periods, even if you haven't met the criteria of 1 year or 6 months or whatever, you should see a fertility doctor immediately. And if you have any known or suspected tubal disease or something called endometriosis, you should also just go see a fertility doctor immediately. So obviously we work, reproductive endocrinologists and infertility specialists like myself. We've done a specific, fellowship in training for 3 years in infertility, but we work closely with your OB/GYN so that we can get you pregnant. And then we send you back to your OB/GYN around 10 weeks or so that they can help you, throughout the rest of the pregnancy and deliver the baby. So when someone comes to me for infertility and, I do a basic workup, I want to check those 3 things. So I want to check the males, I want to check the sperm. I want to obviously, check out the female's anatomy. So make sure the tubes in the uterus are normal. To look at the tubes, I look at something, I inject dye into the uterus. And take an x-ray image. And as long as the dye flows out of the tubes normally, I know that they're open. And that's what we're looking for, to make sure the tubes are open so that an egg and a sperm can meet. And then looking at the uterine cavity itself, making sure that it's nice and clean and ready to receive an embryo implanting. I do something special called a saline ultrasound, which is an ultrasound, transvaginal ultrasound, where we inject water into the uterus at the same time to open it up, to make sure there isn't anything inside of it, like a polyp or fibroid or something that's blocking the ability of a baby to implant, or scar tissue. And then finally, we want to make sure that you have eggs and that you're releasing eggs every month. So we're looking at the ovarian function. So to make sure that you have eggs, I'm going to check your ovarian reserve. So age tells me a lot. You're born with all the eggs, and I'll get into this later, but that you're ever going to have. When you're growing inside of your mom's belly, you have 6 million eggs. By the time you're born, you only have 1 million. By the time you had your first period, you have 400,000. And by the time you have menopause, you have 1,000. So every day, since the day we were inside of our mom's belly growing, we are losing eggs. Again, we lose 20 to 30 eggs a day. They just get reabsorbed by our body and die, and we can never use them again. It's very depressing. But we only end up ovulating, 1 lucky egg a month. So we only ovulate actually 400 of the 6 million eggs that we were originally given were inside of our mom's belly growing. As we get older, our egg number declines with age, right? And so does the quality of the egg. But in order to kind of figure out the quantity of eggs that you have and sort of how close you are to menopause, inside of your body, you could look, if you're 30 years old, you could look like a 20, 30, or 40-year-old. So we got to do some tests to kind of figure out how close you are to menopause, how many eggs you have left. That's called your ovarian reserve. So we check 3 important blood tests. And then we also check some tests, even if you have adequate egg count and you're young, even if you have eggs, we want to make sure that you're releasing your eggs every day, every month. So that's called ovulation. And, and the easiest way to tell if someone's ovulating is if they're having a period every month and never skipping a period. But if they have any sort of irregular periods or skip months, sometimes they could have something going on with their thyroid or prolactin hormone that can also lead to infertility. So we want to check their ovarian function in that way. So for the sperm, we look under a microscope at a bunch of sperm, and this is what it looks like. And then we sort of count all the sperm in a square, and we multiply it by the number of squares that we know are on the grid and by the volume of sperm that the man gave us. And so we find out what's called the total total sperm count. We look at all these different parameters. That's very important, obviously. And treatment, really, if the sperm is great, you should be, and everything else is good with the woman, you should be able to have intercourse and have a baby. Typically, in order to have intercourse and have a baby, you want to have at least greater than 20 million sperm in a sperm sample, total moving sperm. But if you have between 5 and 20 to 40 million, you usually need to do an intrauterine insemination where we inject sperm directly into the uterus. And then if a man has less than 5 million, you typically are going that you don't have enough sperm to meet an egg in the tube, in the tube to become an embryo. So we're going to need to take a sperm and inject it directly into the egg, called intracytoplasmic sperm injection. So that requires us to do IVF. And so in vitro fertilization, where we take the eggs out of a woman, put them in a dish, and then we take the sperm and either, inject the sperm directly into the egg, or we just let the sperm swim and find the and fertilize the egg on its own. Either way, it's, if you have that many sperm, you're going to need to do, IVF. So again, looking at, do you have eggs, and are the eggs being released every month? So there's a lot of, do the blood test to make sure you have eggs. And there's a lot of different reasons why people have low egg count for their age, or low egg count, which is called diminished ovarian reserve. You can have, obviously, as you get older, you have less eggs. You can have a family history of having menopause, like if your mom had menopause before the age of 40, or at an earlier age, then you're more inclined to have menopause earlier. The average age of menopause in the United States is 51. So if your mom had menopause a little bit earlier, you're probably going to have it earlier as well. And then there's some women that can have premature ovarian insufficiency, where their ovaries shut down even way before the age of 40. And so that could be due to many different reasons. One of them is due to, Turner syndrome, which is like a chronic thing, as well as Fragile X. Also, if you're a Fragile X carrier, you can have premature ovarian insufficiency. And so then again, we want to make sure that eggs are being released every month. If you're skipping your periods, you're probably not ovulating. And the main reasons are either due to thyroid, prolactin, or polycystic ovary syndrome, PCOS. So like I said, you want to make sure you are having a period about every 4 weeks and never skipping a period. So cycle day 1 is the first day you bleed. Cycle day, 14 days later, 2 weeks later, you should be releasing the eggs, right? So your brain is sending a signal to the ovaries to grow an egg every month. That signal from the brain is called follicle stimulating hormone, or FSH. So it tells the egg to grow bigger and bigger. And then after 2 weeks, the egg is so big that another special ovulation hormone is secreted for just a second. And that causes you to ovulate or burst open, release the egg from the follicle. And so the egg is released into the fallopian tube, where it hopefully meets a sperm to become an embryo in the tube. And then that embryo will then implant into your uterus. After you've released the egg from the follicle in the ovary, your body starts releasing a hormone called progesterone. And it basically helps the lining of the uterus stay in there, and it acts as glue. And it says, hey, I just released an egg. Don't have a period. Don't shed this uterus lining, because I might have a baby implant. And so it stays around for 2 weeks, releasing progesterone. If after 2 weeks after you've released the egg, the body doesn't detect a baby implanted in your uterus, then it says, oh, you missed your chance. You didn't have a baby, implant. So I'm going to go ahead and stop releasing progesterone. So that glue goes away, and then boom, you have a period. You shed the lining of your uterus. So normal women should have 2 weeks to grow an egg and 2 weeks to maybe make a baby. That's the total of 4 weeks. And then you have a period, or menses is what we call it. So every 4 weeks, you should have a period if your body is working correctly. And that's the reason why. If you don't have that working correctly, usually it's due to one of those 3 things there. So anatomy, I mentioned earlier, we're going to look at your fallopian tubes through that X-ray dye test. We inject dye into the uterus. and then watch it spill out of the tube. And we know that the tubes are open if the dye spills out. So you can see the left tube here is spilling and the right tube here is spilling. And this is that saline ultrasound where we're making sure there aren't any big defects in the cavity of the uterus. So uterus should look like an upside down triangle like it does here. And if it has defects, we'll be able to see that. Okay, so fertility treatment. So the first treatment is ovulation induction with just taking oral pills like Clomid and Letrozole. We can do that for a couple. Again, it has to have sufficient amount of sperm. Tubes have to be open, typically at least one tube. And then we help you ovulate with giving you a pill called Clomid or Letrozole to help boost ovulation. If the sperm is like a little bit borderline, we can add in an intrauterine insemination of the sperm, where we inject we take your husband's sperm and we concentrate it down into a pellet, and then we place the sperm directly into the uterus, called an intrauterine insemination or an IUI. And then finally, if you have too low of sperm, your tubes are blocked, or you fail these other treatments, or you're older and you have a reason you want to do IVF, you can jump straight to in vitro fertilization, where instead of just one egg growing a month, like normally happens with these pills, usually you grow a few more eggs than one a month. And then with IVF, we try to grow as many eggs as we possibly can. And then we have your egg retrieval, fertilize the eggs with the sperm, and then create the embryos. And then you can do a biopsy of the embryo if you want to look for genetic chromosomal abnormality, which we'll talk about in a little bit. And then we put the embryo back inside your uterus as a transfer. So those are kind of the different tiers. So the first one is just pills. The second one adds in the sperm. And then the third one is just full on IVF, where you go to sleep under anesthesia and we take your eggs out, as many as you can that day. But that doesn't put you into menopause any earlier. You don't lose more eggs, nothing like that. It's just the eggs that would have died that month, we're going to recruit them to grow. Okay, so what I really want to talk about, sorry it's taken so long to get here, is infertility prophylaxis. So how do we prevent infertility from happening in these women? So we can encourage them to freeze their eggs at a young age when their eggs are good, because we don't know who's going to go into menopause early. We don't know what age they're going to be ready to start trying to get pregnant. We don't know when they're going to meet, the right guy, or if they're going to be the right guy. We want to freeze their eggs, right? Before it's too late. So also we do this for women that are diagnosed with cancer right before they undergo chemotherapy, because that can damage eggs. So we do that as well. Okay. So my story, again, lots of medical training, on this long path of becoming a doctor, a fertility specialist. And so at the time, at this time, 37, not married, no family, no kids. Was it worth it? I have the best job, best dog, best house. But the best part is that I have actually more eggs than this frozen. I have about 40 eggs frozen now. And so that's the best part. I feel like a huge relief knowing that I have young eggs frozen. I started when I was 28. So I'm a huge advocate for egg freezing. My mom had menopause at an early age. She had menopause at the age of 43, which is early because the average age of menopause is 51. So I was scared. I knew at 28, I was going to be on this long path to becoming a doctor, and I didn't know if I was going to be the right guy. So I wanted to freeze my eggs. And so now I've done it, a lot, 5 times. So why do I have so many eggs frozen when I don't need 22 babies? But I know that, based on the age at which I froze my eggs and the number of eggs I had frozen, with 22 eggs, I had a 92% chance of having 1 baby, a 71% chance of having 2, and a 44% chance of having 3 live babies from those frozen eggs. So as we get older, right, we talked about the fact that the quantity of our eggs declines with age, right? But also as we get older, the quality of our eggs declines. And I'll talk to you about that now. One of the things we can do to check your quantity of your eggs at any given time is check your AMH level. That will go down with age. Okay. So you can ask your doctor to check that, or fertility specialist. And like I said, you're born with all the eggs that you're ever going to have, and it decreases sharply. So we only, we lose 20 to 30 eggs every single day. They just get reabsorbed by our body, and we only ovulate 400 eggs. Okay. So we're born with all the eggs that we're ever going to have. Number decreases with age. Once we hit the age of 35, it decreases even faster. Okay. But also when we're under, our younger eggs are considered smart eggs. So when we're young in our 20s, our eggs are considered smart. And when an egg and a sperm get together to create an embryo, and that embryo starts to divide, there are always errors that occur, but young smart eggs can correct those errors and result in normal, healthy babies. After the age of 35, our eggs aren't quite as smart. So when an egg and a sperm get together after 35 to create an embryo, and the embryo starts to divide, and those errors occur, we can't correct them as well. So we end up more often with babies that have like chromosomal abnormalities, like Down syndrome, which is trisomy 21. Usually that will end in a miscarriage, but it can also end up in a newborn that has that. So as we get older, the chance of a newborn with a chromosomal abnormality is much, much, much higher. In fact, you can see here at the age of 30, the chance of you having a baby born, because again, usually that ends in a miscarriage, but born with a chromosomal abnormality is 1 in 385. At the age of 45, it's 1 in 21. So it really increases with age a lot. Okay. So, but usually you'll have at the age of 45, probably 98% of all your eggs are going to lead to this Down syndrome or chromosome abnormality. But the fact that those that if it may survive to delivery, and of the children born when you're 45, 1 in 21 will have it. So usually it ends in a miscarriage though. So as we get older, our miscarriage rate increases and our fertility decreases. So Shady Grove Fertility, where I work, we did the largest egg freezing study in the country. So looking at women's, how many eggs they would need to have frozen in order to have 1 in blue, 2 in red, or 3 in green children. Okay. So based on your age, so let's just say you're, 32. Okay. If you had 20 eggs frozen at the age of 32, you would have a 85% chance of having 1 baby from those eggs. You would have a 50% chance of having 2 babies and a 25% chance of having 3 if you're 32 and you froze 20 eggs. If you're 32 and you froze 30 eggs, you'd have a 95% chance of having 1 child, 70% chance of having 2, and a 45% chance of having 3. So it gets harder as you get older. So you really want to do this as young as possible. Okay. And you want to freeze as many eggs as you possibly can too. So that study was only based on age, but remember, there's a lot of things that go into, what your likelihood is of getting a lot of eggs. Just not just your age. You want to look at how many eggs you have on the ultrasound, which is called the antral follicle count. And this is what the follicles look like. And each follicle should have an egg inside. You want to look at your AMH level and your FSH level, which your doctor or fertility specialist will check. And so, by the way, you can see a fertility doctor whenever you want to get this stuff checked out. You don't need to meet the definition of infertility or even have a partner. You just go and you say, I want to know about my fertility, and you don't need a referral or anything. You just make an appointment. Okay. Common misconception. At Shady Grove, we have an IVF egg prediction model. Basically, it tells us how many eggs you're going to get from 1 round of IVF. And so we plug in your age, your AMH, your follicle count, your FSH, your BMI, and then some other things that aren't as important. But we find out how many eggs you're going to get on an egg retrieval, and then what the chances of you having a live baby from your first egg retrieval cycle, what the chances of you having a live baby from your second cycle, and then from a third cycle. So we can plug those numbers in and find that out for you. And so let's just explain the drop off, why you need so many eggs to get just 1 baby. So if you're under 38, we generally say you need 10 eggs to get 1 baby. If you're 38 and above, you need about 15 eggs to get 1 baby. Okay. The reason is because let's say you freeze your eggs at the age of, 30. Okay. And 2 years later, 3 years later, you've met the right guy, you're ready to thaw the eggs, or you just want to use donor sperm, you want to get pregnant. So you thaw the eggs and only 90% will survive the thaw. Okay. And then you take those, so you've now have 9 thawed eggs. Then you take those and you try to fertilize them with your partner's sperm. Only 75% will fertilize normally. So now you're down to 6 to 7 embryos. And then you have to grow the embryos out in the lab for 5 days to become high quality that will survive in your uterus. That's also known as a blastocyst. Okay. And only 30% will survive to day 5. Okay. So now you have 2 high quality embryos. You put 1 embryo back at a time and only 50% chance of implantation. So again, for every 10 eggs, you need for every 1 child you want, you need about 10 eggs if you're under 38. Okay. All right. So why do you remember that 22 eggs doesn't mean I'm gonna have 22 babies. There is still an 8% chance I might have 0 babies from my eggs. And you never have to use your frozen eggs. It's just there to make you feel better about, not settling for the wrong person. Okay. So our egg thaw outcomes are really good. So like in this year, 2018, we had 129 women under the age of 35 come back to use their eggs. We thawed 1,000 eggs. Each woman had about 8 eggs, and there was a 40% chance of pregnancy from those eggs. And a lot of women had extra embryos frozen for like their second and third baby. So when should you start freezing your eggs? You want to think about all those things that we talked about. And also your family history, when your mom had menopause, how many children you think you may want to have, when you think you're going to be ready to start trying to get pregnant. Obviously, if you're single, what your career goals are. And, if you have like this long road ahead of you, and if you're financially stable, when you think you're going to be financially stable to have children, or, in that place where you can. So luckily, women are getting older when they're having their first child. And, so you can see here with time, it only goes up to 2010, but, women are getting older having their first child. So that's good. So the goal of egg freezing, of course, is to keep your fertility potential at its current state right now as a 30-year-old or however old you are. Okay. And so we just stimulate the eggs that would normally have died that month to be used. And egg freezing technology has significantly improved over time. Not going to go into detail on this slide, but basically our birth outcomes have significantly improved from using frozen eggs. It's almost equivalent to using fresh eggs. So I would definitely freeze eggs. Okay, so again, getting started, we'll check your blood test and do an ultrasound to kind of figure out where you are in the timeline of everything and what your egg reserve is. And then for the stimulation of egg freezing is the same as in vitro fertilization. So if you have a partner and you're trying to do, and you need IVF, or if you're single and you're doing egg freezing, you're going to do the same thing in the beginning. So you're going to take 2 weeks of injection medicine. So instead of your brain releasing the hormone or signal to grow 1 egg a month, you're going to inject yourself with that same hormone to grow as many eggs as we possibly can, but at a much higher dose than your brain releases. So instead of 1 egg, we're going to try to grow as many eggs as we possibly can. And then after 2 weeks, your eggs are going to be so big that they're going to be ready for the egg retrieval, where you come to our office, you go to sleep under anesthesia. We put an ultrasound probe in the vagina with a little needle that goes through the vaginal sidewalls and into each of your follicles that have the eggs inside. And so this is what it looks like. So your eggs start really small, your follicles start small, then they grow bigger and bigger. And 2 weeks later, you're ready for your egg retrieval. You're asleep under anesthesia. Ultrasound probe goes in the vagina, little needle goes into each of the follicles. And it's a hollow needle. It's connected to suction. So we suction out all the fluid inside of each of the follicles. You do have to come to our office during these 2 weeks for ultrasound and blood work every other day to make sure that you are responding appropriately to the medicine. So you'll see your eggs getting bigger and bigger, lots of ultrasounds and blood work. Your eggs will start small. You can do this with an IUD, and if any of you have that. And then, eventually your eggs get really big and your estrogen gets really high. And so then you're ready for what's called the egg retrieval, where, and this is sort of what a timeline looks like. So you have 2 weeks of stimulation and then your egg retrieval. And then you get a period 1 to 2 weeks later, and you can do it again at that point if you don't have enough eggs or enough embryos that you've created. So no time is a good time, but right now is the best time. Everyone has things coming up, baby showers and weddings and all these things, but you have to make it work because your eggs are younger now than they're ever going to be. And then you come in for your retrieval, go to sleep under anesthesia. We get an egg out. This is what an egg looks like under the microscope. And then you've gained a lot of years back of your dating life. And I usually walk my patients through this calculator. It makes them feel a lot better about how they've gained back certain years of their dating life. So if you're single, if you met the right guy tomorrow, how long would it take until you got engaged? How long of engagement? How long until marriage? And then how long until you're ready to start getting pregnant? You gain all that time back, okay? Because you're freezing your eggs now. And you can focus on yourself and your career and meet the right guy. So there are risks associated with IVF and egg freezing. I'm not going to go into them because I really want to give Dr. Pizer some time to talk. But they're very low risk, less than 2%, okay? I rarely see any of these. But your doctor will talk about them with you. And then we can store the eggs for you to use forever. We allow you to use your eggs up until the age of 51, even after you've gone through menopause. If you get through menopause at 40, we can help you carry a baby As long as you've created your eggs before the age of 45, we can help you and use those eggs until you're 51. So you need to freeze as many eggs as you possibly can. In general, we say 15 to 20 if you're under 37 and 25 to 30 if you're over 37. And then you might need multiple egg freezing cycles or IVF cycles to get that many eggs. And then when you're ready to use your eggs, you just thaw them and you fertilize them. So now I just want to quickly, I know you guys had talked about financial stuff. So an egg freezing cycle is how all fertility clinics kind of say, financially what you pay for is within a cycle typically. And so a cycle includes usually like your ultrasound and blood work. So all of your monitoring appointments, then the egg retrieval, we're under anesthesia, the actual freezing of the eggs or embryos, and the fertilization of that, and then the first year of storage. And you can look up on different websites, like Fertility IQ, is one of the websites people look up on, like to learn about the stats of the different clinics around you. And you can find out kind of how much things cost. But in general, an egg freezing cycle, for example, is a lot. It can be up to, 11 plus 5 plus 2, that's $18,000. But at Shady Grove, we have really good, amazing financial options where for one cycle, it's $7,800. And then you can do this program called the Assure 20, where we assure you get 20 eggs frozen or 4 cycles, whichever comes first, for $13,000, or the Assure 30, where you do 30 mature eggs frozen or 5 cycles for $19,000. So it's really amazing programs. I know it's a lot of money, but obviously it's worth it to make your family. Okay. And then just so you know, for IVF, a single cycle of IVF is typically about, $15,000, including your cost of your egg retrieval plus the freezing cost. Every time you transfer an embryo, it's about $5,000. Okay. So it can add up if you pay for a single cycle, but like Shady Grove, we have these packages where you can pay, like we have a guarantee of a live baby, or else you get 100% refund. If you qualify for this program, it's called our shared risk program. It varies on cost based on your age, but it includes all the up to 6 IVF cycles until you get a healthy live baby and unlimited embryo transfers. We also have programs for 2 cycles, and these are the costs right now. They change every 6 months to a year, but these are them right now. So, anywhere between $20,000 and $35,000, depending on which program you go into. But they're really amazing programs. And follow me on Instagram. I talk all about egg freezing and injecting yourself with all these medicines for infertility. Valerie Levy, MD. And obviously we have offices all over the country for, to talk, and we can speak virtually and see patients out of state. But yes, thank you. Let us know if you have any questions.
Thank you so much, Dr. Libby. I'm now going to introduce the next panelist. Dr. Prizer, Dr. Alex Prizer, MD, is a board-certified OBGYN reproductive endocrinology and infertility at Northwell Health. She completed her undergraduate degree at Columbia University with a major in electrical engineering, and then earned her medical degree from the Technion Israel Institute of Technology. She completed her residency in obstetrics and gynecology at North Shore University Hospital and Long Island Jewish Medical Center, where she served as the administrative chief resident. She has published and presented at numerous national meetings on the topics of genetic carrier screening, donor egg use, fertility insurance coverage, and the genetics of diminished ovarian reserve. And without further ado, I will let her speak.
Thank you. I'm going to share my screen. All right, someone just give me a heads up that you see it.
Yes, yes.
Okay, great. So thank you, Joma, so much for having me, and thank you, Dr. Libby, for a great intro and talk. I'm going to be talking about secondary infertility as well as male factor infertility and amenorrhea, and we're going to touch upon a few topics. So let's just get started. So in order to understand secondary infertility, we need to understand what primary infertility is. And primary infertility is defined as the inability to become pregnant after 6 to 12 months of trying with unprotected intercourse. Secondary infertility is defined as the inability to become pregnant or carry a baby to term after previously giving birth. Now, it's important to understand that the causes of secondary infertility are, for the most part, the same as the causes of primary infertility, and we'll go through them. So some basic statistics. 12% of couples who already have a child may go on to have secondary infertility. This was a study that I found from 2015 that looked at about 1,000 infertility patients and found that 31% of them had primary infertility and 69% had secondary infertility. So why do we see sometimes this increase? So really, we have changes in hormones as we get older, risk for certain diseases as we get older, and these can all impact fertility, and we'll go through them. So what are the causes of secondary infertility? We like to divide it in thirds. 1/3 female, 1/3 male factor, and 1/3 could be both or unknown. And our job as doctors is to try and figure out what's going on exactly. So some of the causes of secondary infertility are advanced maternal age, male factor. You can have a problem with sperm production, low sperm count, tubal factor. We need to make sure your tubes are open. Ovulation dysfunction. We need to make sure you're ovulating, make sure you have an egg each month. Uterine conditions. We need to make sure the uterus is ready for a pregnancy and that it's accepting a pregnancy. Lifestyle factors, smoking, heavy alcohol use, these all affect our fertility. Certain medications and endometriosis. Sometimes it's unexplained and we don't know the reason, and this can be frustrating for patients. And 1 in 5 cases are often unexplained. So let's go into maternal age. So we said as women get older, there's a natural decline in their fertility. So here we're looking at a chart where the percentage of eggs that are normal are on the y-axis and female age is on the x-axis. And as you get older, this percentage of normal eggs declines. And we may not be able, the eggs may not be able to fertilize well. They may not be able to implant as well into the uterus. And every woman is different. And that decline can either begin earlier or later. We don't really know, maybe family history related. But because fertility declines with age, it's possible and even common for women who had no trouble conceiving with their first child to have difficulty as they get older getting pregnant. And then again, this is another chart looking at maternal age on the bottom with the rate of increasing in miscarriage as we get older and a decrease in fertility as we get older. So very important age. Another thing that's extremely important, tubal factors. We need to make sure your tubes are open. As you ovulate each month, an egg is released, 1 egg. Sperm goes into the uterus and finds that egg in the tube. And it fertilizes in the tube and then travels down the tube and implants into the uterus. We need to make sure your tubes are open. So what do? We do a test called hysterosalpingogram, HSG. It's an X-ray test where we put dye into the uterus and we're able to see if your fallopian tubes are open. So you can see over here, the right tube, there's spill. So we know your right tube's open, and over here, your left tube's open. So we see spill of dye. So it's very important. Sometimes the tubes are blocked, and this is a picture of hydrosalpinx. That's a tube that has fluid in it, and it's associated sometimes with infection. So we can sometimes clip the tube or take them out, and we can do IVF and sort of bypass the tubes. Sometimes we see proximal tubal blockage. So that's blockage at the area where the uterus meets the fallopian tube, right at that tip. And we can open it with a procedure that we're able to put like a balloon in and open it, or a wire in and open it. So it's just important to know. There's also another test that we can do to look at tubes, and it's called a FemView or HICOSI, and it stands for hysterosalpingo-contrast sonography. And we use ultrasound with water and air bubbles to put that into the uterus, and we look at the tubes under ultrasound guidance, and we see the flow of these air bubbles through the tube, and we're able to see whether your tubes are open. Ovulation dysfunction is another reason why someone may have secondary infertility. we need to make sure you're ovulating, releasing an egg each month. So what are reasons why you may not be ovulating? One, PCOS, polycystic ovarian syndrome. That's a condition where you have a hormone imbalance, which may disrupt the normal response of creating and releasing an egg each month. You may have problems with your weight. You may have extreme exercise, high levels of stress, prolactin levels, thyroid, low ovarian reserve, or premature ovarian failure, all reasons why you may not have normal ovulatory function. Uterine factor, we need to make sure your uterus is ready for a pregnancy. So there are many conditions related to the uterus that can cause secondary infertility. Uterine anomalies, they may be shaped differently. Polyps, fibroids, those are benign, non-cancerous growths inside the uterus that can impair pregnancy. And scarring can occur after a D&C or after a C-section, that it may cause adhesions within the uterus and impact implantation. So here are common uterine anomalies that we may see. Here's a picture of a normal uterus. This is a didelphys uterus. It has 2 cervixes and 2 horns. This is an arcuate uterus, which is a form, a normal variant, and you can still have a successful pregnancy with this. Unicornuate uterus, where you have 1 horn, bicornuate uterus, 2 horns, 1 cervix, septate uterus, you have a septum in the middle of your uterus. And these are important to know because they may increase risk for miscarriage, preterm delivery. It's just important to know what exactly is going on. So how do we diagnose uterine anomalies? We can use ultrasound, transvaginal, transabdominal, 3D. This picture on the bottom here is a 3D ultrasound, and it's extremely helpful to see the contour of the uterus and what it looks like. We can use an MRI to help us diagnose ovarian, uterine, or congenital malformations. HSG, which I spoke about, the X-ray test. Sonohysterography is a water ultrasound to look inside the uterus for polyps, fibroids, and hysteroscopy is a definitive method. We take a camera inside the uterus and we're able to actually see what's going on. Over here on the right is ASRM, the American Society for Reproductive Medicine, our governing body, Mullerian anomalies classification, and they just came out with a new one in 2021. It just shows all the variants, the different types of variants of uterine anomalies. And you can go online and search it yourself and see just all these different kinds of anomalies that exist. So an endometrial polyp. This is a picture of a water ultrasound where we put water inside and we see these 2 polyps that are there. Polyps are focal growths inside the uterus. It's estimated that about 10% of the general female population have polyps, and it can cause a problem with implantation. So what do? We'll take a hysteroscopy, which is a camera inside the uterus, and we'll see the polyp. This is what it looks like, and we'll take it out. Usually it's under anesthesia in an operating room, and you'll go home the same day. Very simple procedure, very common. Uterine fibroids. The uterine fibroids are smooth muscle growths, and their prevalence are extremely high in infertility patients. Fibroids can be the reason of infertility for 2 to 3% of women, and depending on their location in the uterus, it has been associated with recurrent pregnancy loss as well as implantation failure. So we need to know where the fibroid is. Is it on the outside of the uterus? Is it causing any problem to you? Any bulk symptoms? Do you feel any pressure? Or is it inside the uterus? If you want to get pregnant, we need to remove the ones that are inside because it's impacting your fertility. So options for fibroid treatment are conservative management if they're not affecting you at all, surgery if they're inside your uterus. We can give you medication also to decrease the size. In older patients who may have abnormal uterine bleeding from fibroids, we can do a procedure with interventional radiology where they basically decrease the amount of blood flow to the fibroids and help shrink them, but not for patients who want to get pregnant. Adhesions. So adhesions in your uterus may be another cause for secondary infertility. So this is a normal uterus, and this is a uterus with adhesions, and we call it Asherman syndrome. And sometimes it's from, like I said, a prior miscarriage with a D&C, or retained placenta from a previous delivery. And what we do, this is under hysteroscopy, what we see, we will go in and we'll clean up the uterus and get rid of the adhesions. Endometriosis. So endometriosis is when cells from the uterus, endometrial cells, grow outside the uterus. And this may impact fertilization, causing a sort of toxic environment. It may cause pelvic adhesions. It may cause diminished ovarian reserve. It may cause endometriomas by the ovary, which we call chocolate cysts, and could cause implantation dysfunction. We really, when you have your period each month, you want to menstruate all the blood out. But one of the theories is that the blood actually travels backwards and may implant in places that we don't want it. So common symptoms of endometriosis are really bad pain during your period. So if you have that, make sure to tell your doctor. Treatments for endometriosis, medications to suppress the endometriosis. We can do surgery and fertility treatments as well. Okay, so let's talk about male factor infertility. So again, that accounts for 20 to 30% of infertility cases. So this is a picture of what a sperm count should look like, normal, and this is someone with a low sperm count, so there's less sperm. This is sperm morphology. We look at, is it normal? Is it abnormal? And we also look at sperm motility. Does it flow nicely or does it not? So it's important for this talk and for everyone to understand how the brain works, how we make our hormones. So both males and females have something called the hypothalamus pituitary gonadal axis. So in your brain, you have the hypothalamus that releases GnRH, gonadotropin releasing hormone, to your anterior pituitary, also in your brain, which releases LH, luteinizing hormone, and FSH, follicle stimulating hormone. In the female, the ovaries respond from these hormones and produce estrogen or progesterone. In males, they produce testosterone. If there's any problem or any disruption in any levels, we may have a problem down the line with your infertility. So for males, these are the causes of male factor infertility. I like to think about it in three ways. One, you may have a problem with that hypothalamic pituitary axis over here. You may have a problem producing sperm. This is primary gonadal disorders over here. Or you may have a problem with sperm transport. Sperm is produced, but it's not getting out. So I'm just going to touch upon some of these. So with hypothalamic pituitary, you may have a problem with GnRH production, that's idiopathic gonadotropin deficiency. You may have tumors that may be disrupting the stalk in your brain. There may be drugs, steroids, or opioids that may be suppressing gonadotropin secretion. You may have an injury or infection or chronic illness that's causing a problem with the stimulant. With primary gonadal disorders, you have a problem again producing testosterone. This is caused by sometimes Klinefelter syndrome. It's a genetic condition where a male is 47XXY, which is abnormal, and that causes them to not have sperm at all. Or Y chromosome deletions, the same thing. A man may have a varicocele, which is a dilation around the testicle, which is supposed to help with blood flow from the testicle. And if it's dilated, it may cause problems with production, infection, radiation, chronic illness, environmental, or drugs. And disorders of sperm transport, the sperm is not getting out. Why? There may be an obstruction. There may be an infection. There may be ejaculatory dysfunction. Another common thing is called CBAVD. It's congenital bilateral absence of the vas deferens, which brings the sperm out, the vas deferens, and that's common in cystic fibrosis carriers. So it's important to know. For the male workup, we do a semen analysis. It can vary widely over time. Normal parameters are here and important to know. The volume 1.5 cc, concentration 15 million, per ml, motility 40%, morphology 4% normal. Reasons for reason that someone may have a semen analysis abnormality. If there's a problem in the volume, it could be due to CBAVD or erectile dysfunction, anxiety. If there's a problem with concentration, a varicocele could be the problem. Problems with production. If there's a problem in motility, again, varicocele, or morphology, tobacco, alcohol, heat. So we have to figure out exactly what's going on. So treatment for secondary infertility, male factor infertility, Dr. Libby mentioned ovulation induction. We try and stimulate you with medication to get more eggs. We can do intrauterine insemination where we take the sperm and inseminate it into the uterus, bypassing the cervix. We can do IVF, which she spoke about, and intracytoplasmic sperm injection, ICSI, with IVF is really for male factor patients where we take one sperm and inject it into the egg to help with fertilization. Okay, now we're just gonna touch upon the last topic, amenorrhea. So let's define it. So primary and secondary amenorrhea. Primary is the failure of onset of menses by age 14 without secondary sexual characteristics. And secondary sexual characteristics are breast and pubic hair, or no menses by the age of 16 with secondary sexual characteristics. Secondary amenorrhea is when there's no menses for 3 cycles or 6 months in the absence of pregnancy or lactation. So I just wanted to show you, this is from our guidelines, that there are so many reasons why someone may have primary or secondary amenorrhea. And you really have to look closely as to what exactly is going on. So how we categorize it, it's either disorders of the outflow tract, problems with the uterus. You're not something's stuck in the uterus, not letting you have your period. You may have a disorder in your anterior pituitary or your hypothalamus. It could be congenital, you're born with it, or acquired. So what we like to do, this is for primary. I usually look at the FSH, and this is back to our schematic. If you look at the FSH, it can tell you what's going on. If there's a high FSH, then there's usually a problem within the ovaries, some genetic problem, Turner syndrome, Swires, radiation chemo that turned off the signal from your ovaries. If you have a low FSH, it makes us think that there's something with production in the anterior pituitary. You may have Kallmann syndrome, which is a production in abnormal production GnRH. A craniopharyngioma is a brain tumor that may cause a problem, or anorexia. If you have a normal FSH with amenorrhea primary, you may have androgen insensitivity syndrome, Mullerian agenesis. You may have anatomical defects that may be causing it. Secondary amenorrhea, you have had menses in the past, but you haven't had it for 3 cycles or no menses over a 6 months period. So what's going on? It could be due to weight loss, anorexia, could be related to your hypothalamus, could be due to PCOS, hypothyroid, Cushing syndrome, which means you have elevated cortisol, pituitary tumor, anatomic, you have a problem in the uterus, or high prolactin. So again, the same thing, the workup for secondary is we need to do a history. We need to rule out pregnancy, get an FSH and a prolactin. We look at them and it helps us determine exactly the pinpoint area that we should be looking at. One thing I wanted to just touch upon is hypothalamic amenorrhea, which comes up a lot. It's a diagnosis of exclusion, and it's based on findings of low or normal serum FSH concentrations and low levels of estrogen. So when we look at your labs, we'll see that you have low estrogen and low FSH, and it's associated with extreme physical, nutritional, or emotional stress. So patients who are usually underweight or report a recent weight loss or engage in strenuous exercise, there may be a problem with them ovulating. The signals may be turned off. So we need to look closely at that. Treatments for secondary amenorrhea really depend on the underlying cause. It could be due to weight management. We need to help you with your weight, stress. We need to adjust your physical activity, birth control pills to try and help you get back into cycle, ovulation induction, a DNC hysteroscopy if a problem is inside the uterus. So in conclusion, just to bring everything together, when to start your infertility workup, if you're less than 35 years old, If you have a failure to achieve a pregnancy in 12 months with regular unprotected intercourse, see a fertility doctor. Greater than 35 years old, 6 months. Older than 40, come in. You can initiate it sooner if you have oligomenorrhea, irregular periods, amenorrhea, uterine tubal disease, endometriosis, male fertility, see your fertility doctor. So just 2 myths that I see a lot. If I eat well and am healthy, that means my eggs are also staying healthy. Is that true? No, false. Eggs don't respect your healthy lifestyle. Age is the biggest factor that influences female fertility. And the second myth, if I do egg freezing or IVF, the number of eggs I have left will be reduced. I get this question so many times. No, this is not true. Egg freezing and IVF just stimulate the eggs that normally would be thrown away during a regular cycle. You're not losing any more eggs, and it's not affecting your natural fertility. Thank you, Joma, for having me. And I hope you guys learned a lot tonight.
At this point, we will transition to the Q&A portion of our event. Before we begin, I'd like to remind everyone that this forum does not constitute individualized medical advice. So please keep your questions broad. This constitutes our webinar on infertility. Thank you so much we'll just start with the questions. So the first question is there a formula or rough guide for how long a woman has to get pregnant based on AMH?
Alex, if you have anything, I mean,
Yeah, start.
Okay, is there a formula or rough guideline for how long a woman has to get pregnant based on AMH? So there isn't a formula that I'm aware of. I mean, I would say speak to a fertility specialist about your specific AMH level, and they can tell you sort of how long, they'll talk to you about, how big how many children you want to have, when you think you're going to be ready to start having more children, or have the rest of your children, or have your children at all. And then they can tell you kind of what they think, when they think if your ovarian reserve is adequate or a little bit low, and if you should consider, doing prophylactic measures now, like IVF. There isn't, a formula that says anything specifically, but in general, AMH decreases with age, and anything less than 1 starts to get concerning, and less than 0.16 is typically seen in menopause. So hopefully that answers your question. Okay, next question. How consistent do you have to be for you to be considered to have a regular period? Is every 25 to 35 days normal? Yes, that is considered normal. From what I remember, Alex, it's every 21 to 35 days now is now considered normal.
Correct.
I would say anyone that has a period every 21 days, meaning from the first day of your period to the next first day of your period, that is pretty frequent. You might have some sort of defect going on there. You might want to see a doctor about that. But like if you have a period even more frequent than every 21 days, definitely go see a fertility specialist. If your period comes, if you skip a month, or it's longer than every 35 days, that's considered irregular. Okay, done. Next question. Okay, this is an interesting question. What about someone who's been diagnosed with an endometrial polyp that the doctor said is pretty large? Any advice until she gets an MRI to tell if it seems cancerous, to take a biopsy of that she's avoiding to do due to her not being have been sexually active or married yet as a religious girl? Is there a chance that she won't need to get it removed if she shrinks it with alternative medicine? Any contact info? So, that is a very hard question, and something that I don't have much experience with. I mean, in general, polyps can become cancer. So you always want to get them removed, no matter how old you are. There are certain risk factors that will increase your risk of that polyp in your uterus becoming cancer. Things like what your BMI is, like what your weight is, and what your age is. But if you're young and you're very thin, it's, it can still become cancer. So I would definitely want it removed. But typically when they remove that will affect your hymen. So, I don't know of any ways to get around removing a polyp without affecting the hymen. But that is something you need an exam by your doctor, your OB/GYN, to see if possibly your hymen is it can either be put back together potentially after the procedure, or if you can somehow get around it. But I would say definitely talk to your OB/GYN, get that exam done just so they can evaluate you and see kind of what your hymen status is now. Alex, do you have anything else to say? Anything?
No, I agree with that. I think we should see what's going on, probably take a biopsy. Yeah.
Yeah. Okay. So does low AMH impact natural conception rates in younger women? Yes. So in general, AMH is supposed to be used for women like in their 30s. And it's not really been studied that much in younger women in their 20s. So it's not as helpful, but every fertility doctor in the country uses it for any person that comes to see them, whether they're 18 or, 48, so I would still take it and utilize that information. So it is important. If you're trying to get pregnant and you haven't been able to, getting your AMH checked is definitely, a good step. But warning, a lot of OB/GYNs don't know how to interpret AMH levels accurately. So, I wouldn't, if I went to my doctor and they said, oh, your AMH is 1.01, it's fine. Okay. That is not true. It is not fine. Okay. That, if you're 30 and your AMH is 1.01, even though AMH greater than 1 is okay, that's a low for your age. So you really want to get it interpreted by a fertility specialist.
With a low AMH, if you're doing IVF, you may need to do multiple cycles. However, a recent study just came out that said patients with low AMH don't have a difference in getting normal genetic embryos, than a patient with a normal AMH. So that's really reassuring to know.
Yeah, that's probably more related to your age. So that's good. Yeah. So
before you continue with those questions, we got an anonymous question. Does getting my first period at an older age affect my fertility?
I don't think so. No, I wouldn't say so at all.
Yeah, it doesn't.
No difference. Yeah.
No, I got my period when I was 9. So that just, they typically say if you get your periods earlier, you might get, you might go into menopause early, but I don't think it has any correlation at all. So it just stinks. You're gonna have your period for longer years of your life. But yeah, there's nothing. Okay. So if secondary infertility can occur after already having a normal, healthy birth, do you recommend patients freeze their eggs after having a baby if they intend to have more children? Good question. So no, if you are married and you are in a stable marriage that you don't think is going to end, you don't need to freeze your eggs. Let me just clear that up. You do not need to freeze your eggs. If there's any doubt about the stability of your marriage, or you are single, that's when you freeze your eggs. Freezing embryos is a totally different thing. I definitely think, if you have secondary infertility and you want to have a lot, if you have secondary infertility, that means you're trying to get pregnant. Okay. So you're obviously wanting to have a kid again, but if you are not ready to have, if let's say you're 30 and you've had 2 kids and you want to have 2 more, okay, and you've been trying for a year, you have secondary infertility, first of all, and you should see a fertility doctor. And and your AMH is borderline low, so it's 0.8, and you want to have 2 kids and you're 30, okay, then I do think it might be a good discussion to have with your fertility doctor. Should I freeze some embryos? Because, okay, I'm going to have a baby now, and that's probably going to be easy, maybe, okay, but then when I'm ready for my 4th kid and I'm 35, my AMH is going to be even lower. Let me freeze some embryos now. And so an embryo, again, is when you have an egg and a sperm already created and frozen. So you can basically bank your family. You can store these embryos up for you to have a family, as you get older. I hope that answered your question.
I see. When it was said that alcohol and smoking and drugs could cause infertility, we're talking about once in a while usage or heavy usage. We're pretty much talking about heavy usage of alcohol and smoking. Smoking in general, don't smoke. Don't smoke. Don't smoke. But heavy alcohol usage is really the key. You can have alcohol, here and there. That's okay.
Yeah, for sure. Yeah. Okay, so that one's done. If the tube is blocked, how common is removal of the blockage? Okay, so speaking from a clinician that's out of fellowship, out of an academic center, it is much more common if your tube is blocked to go straight to IVF, okay? Because of a lot of different reasons. Number one, if you have a blocked tube and we unblock your tube, okay, you have a very high risk of having an ectopic pregnancy, which can be life-threatening, okay? So we do not recommend that. If you have a blocked tube, as a clinician already practicing, we typically won't even do a proximal tubal cannulation. We won't even do that. We will, we will typically, if you have a distal blockage at the end and you have that swollen tube thing, tube needs to come out, okay? 100% tube needs to come out, okay? That is toxic fluid that will damage and that will decrease your chance of a normal embryo implanting in your uterus. Tube needs to either come out or be blocked, like Alex said, before at that junction, okay? If you have a proximal tubal blockage, typically if you have a bilateral proximal tubal blockage, it's actually just a spasm and you need to get another HSG with Valium and they will open up. Okay, but if you have a unilateral proximal tubal blockage, we typically won't open it. We'll typically say you have a decreased chance of getting pregnant because now it'll be like, it'll take twice as long to get pregnant because you only have one tube working instead of two. And that we would usually say, you can try a few IUI cycles only when you're ovulating from the correct side, or you can do IVF. When you can do IVF, just jump to IVF and we just bypass the tubes.
I wanted to touch upon too, I saw one, what happens if you need to go for labs or the egg retrieval over Shabbos? Can labs, egg retrieval be delayed, or will this affect the number of eggs retrieved? So just tell your doctor that you'd rather avoid Shabbos as much as you can, and we can try and manipulate the cycle to help you avoid it. We'll start you on a different day of the week. We may not need blood that day. There are ways, so just talk to your doctor and we have ways to avoid it. If we need you on Shabbos, then we'll figure it out. But there are ways to avoid it. How does age affect male fertility? It's a great question. The studies, are saying that age really doesn't matter with male infertility. There was a study that looked at just eggs with donor eggs and put male sperm from different donors from different ages, and there was no difference. So, the studies say there's no age-related factor for males. But I think as men get older, there may be some problems, but the studies say no.
Another anonymous question that I just want to put out there. What can someone who previously dealt with anorexia and eating disorders do to better their chances at fertility?
Okay, who previously dealt with anorexia. So I guess the most important thing is she having periods regularly every month now? If she's having periods regularly every month now, she should be okay. And if she's not having periods regularly, most likely she still, needs to gain some weight. And so that will sometimes help her brain system work again and allow her to start releasing eggs again. So most likely she'll need to gain some weight. There may be something else going on with her. If she's gained her weight back and she's a normal weight now, and she still isn't really having periods, then she should be evaluated.
Some question, what happens if you freeze embryos or eggs and don't end up using them? So you can either discard them, you can donate them, you can keep them, and those are really the options.
Yeah. Okay. If you have a low AMH but are under 35, how long should you wait before seeing an REI? If you have a low AMH, you should just see an REI immediately. Okay. I'm 37 with an AMH of 4 PMOL. Okay, picomoles, I guess. My last cycle, they were only able to retrieve one egg in a failed transfer. I'm so sorry. Is there a way to improve the quality of my eggs and AMH? Definitely talk to your fertility specialist about that. There's, a lot of, I don't know exactly what, they did for your IVF, stimulation medications, but sometimes they can change your medications. You might respond better to a different protocol. You with an AMH of 4 at 37, you would imagine that they would get more than one egg. So I would have to look at your protocol specifically to see kind of where I think they could be improved. And usually they would change up your protocol in some way, whether were you growing a lot of eggs and then all of a sudden had only one at retrieval, or were you always only having one egg growing, and if you had a lot of eggs growing and then only one was retrieved, maybe you prematurely ovulated that egg, maybe all the other eggs, maybe the eggs, weren't mature. So maybe you need to change it. They need to change up the trigger injection. There's just a lot of different reasons why that can occur. I'm so sorry, but your doctor should have a plan for you for your next cycle, and hopefully can optimize your situation. And you can always get a second opinion from another doctor in the practice or a different practice, but usually after, it's not, it's hard to go through that because you expect to do a lot better with that, but definitely your doctor should have another plan, I'm sure.
Agreed.
So thank you so much to Dr. Libby and Dr. Peiser. We all learned so much from this talk. Unfortunately, that's all the time we have for questions. This concludes our webinar on infertility. Thank you to all of our attendees for joining and to Drs. Peiser and Libby for speaking today. And please fill out our post-webinar survey emailed to you after the event for a chance to win a $50 Amazon gift card.
Thank you so much. Have a good day. Bye.
Bye, thanks.
If you guys can just stay on for 1 second, just want to take a group picture. Very important. Okay, I'll send it out. Thank you so much for answering all the questions. Feel free to smile. Awesome. Okay, we will send out the link for the YouTube recording.